Well, that was a great talk, and I was sitting here wondering, why am I here today? I'm not a world expert like the other members of the panel are. I'm a clinician. My first lipedema patient that I recall was 28 years ago. I just started at the Cleveland Clinic, and I know I'm taking my own time here, but I think it's important to note that. And my mentor, who was chair of our department at the time, Jess Young, said, well, that's lipedema. And I said, well, how do we treat that? Well, you can't do anything for it. You can try a support hose. And I was a little discouraged. I'm actually an expert in clotting. I'm a hematologist, I'm an internist, and I'm in the section of vascular medicine at the Cleveland Clinic. We see swollen legs a lot. So when Margarita and Karen and I were on the phone call with Cheyenne a few months ago, we thought, what could I talk about? And I volunteered to talk about swollen legs because this is what clinicians, and you probably started with. You might have started with your family doctor, your internist, or maybe a hematologist, less likely, but whoever it was, most likely didn't know what lipedema was. So I have no conflict of interest. So swollen legs are a common problem. In fact, although we see a lot of clotting problems at the Cleveland Clinic, our most common consult is about 6 out of 10 are swollen legs. So it's common to all specialties. There are many different causes. It's really not a disease. It's a sign of an underlying disorder, but it may be a minor disorder or a more serious problem. And this is an article published about 30 years ago from Henry Ford Hospital stating that lipedema is not rare, but the diagnosis is rarely made. And I think you all have probably suffered from that. So why is it so difficult to diagnose? Well, when you're a physician in a busy office and you have 15 minutes, now we have 12 to see patients and follow up, or for a first-time consult, we might have 45 minutes when we had an hour and a half in the past. And then the patient brings in a pile of records, and there are so many different causes of swollen legs. There's heart failure, there's pulmonary hypertension, there's liver and kidney disease, there's endocrine diseases like Cushing's or pretibial myxedema. You could have obstruction of your vena cava, the major vein that connects the legs to the heart. You could have an infection. You could have a blood clot. You could be pregnant. You could be overweight. You could have arterial disease that's so severe that you hang your legs over the side of the bed and they swell. It could be a medication, or it could be something like a venous problem. So some of the more common things that we see in our clinic, in addition to lipedema, is chronic venous insufficiency, in the middle slide, lymphedema, phlebolymphedema, lipolymphedema, and more recently Steve Dean came up with this term, phlebolipedema, and I'm not sure if you do a Google or if you look in Ovid, which is the medical way I do my research on articles. I could not come up, Karen, with one article on phlebolipedema. Am I right with that? Yeah, so not mentioned often. So again, I'm an internist, hematologist. Patient comes in, the legs are swollen, and they may say, gee, my legs are swollen, my shoes are too tight, I might feel stiff, I might be achy, I might have a heaviness, painful legs, or you may have many other complaints that you've mentioned to your doctor. And there are a number of mechanisms that you can have for swollen legs. It could be venous, it could be lymphatic. You could have too much volume if your heart's not working properly. You could have increased capillary permeability, lowered oncotic pressure, or simply obstruction. So a good clinician will start with a history and physical exam. The history, we want to ask, did it suddenly develop or has it been gradual? And if it was sudden, it might be a blood clot, it could be an infection, it could be a muscle tear, it could be gout. But if it's more gradual, it's more likely lymphedema, lipedema, chronic venous insufficiency, a systemic process, and we always have to look at your medications to make sure it's not a medication. So the other questions I will ask, how painful is it? Does it get better overnight when you elevate your legs? Do you have evidence of heart disease, kidney disease, liver disease? Have you had fever or chills or recent weight loss or weight gain? Have you been on a long car trip or airplane trip? Have you been immobilized with the flu 3 or 4 days or more? Have you had recent surgery? Are you pregnant? And then what medications are you taking as well? And these pictures all just go over what I've just mentioned. These are, again, things that the internist, family doctor, or whoever you see, NP, advanced practice nurse, should be thinking about and asking those questions. Why are your legs swollen? Because you started out going to the doctor not knowing you had lipedema. You went in there not sure, why are my legs swollen? And that's our job to figure this out. And all the medications, look at these: Lyrica, ibuprofen, Neurontin, Norvasc, diabetic medications, and tricyclic antidepressants. All of these can cause leg swelling. So a detailed history is very important, and looking at all the medications when you are trying to diagnose, why is my patient complaining of swollen legs? And the physical exam, if it's unilateral, we go down one pathway. If it's bilateral, we go down another pathway. And then we look at where is the swelling. Is it pitting, and is it pitting or non-pitting? Does it involve the foot? Does it just involve the thigh or the calf and no foot? And here are some examples. Now, on your left is a tourniquet. You can't see the tourniquet, but you see the straight line. And this is a young man that came to us. No one could figure out why his leg was swollen. So I always make my patients get in a robe or a gown, and they don't like it all the time, but I won't go in the room if they're not undressed, because simply, how can you make a diagnosis? I walked in the room, I took a look at this guy's leg, and I knew that he was factitious. He had been applying a tourniquet. He was trying to get more disability and didn't want to go back to work. Now, the one in the middle, and you can see all that swelling in that foot, someone at the nursing home was wrapping that individual's legs. Now, it spared the toes, if you look carefully, but the way it was wrapped, I'd never seen anything quite like that, so I have lots of pictures of it. And then on your far right is a great example of pitting edema. So these are the things that we must look at. We look at the color of your legs. Are you red, like cellulitis? Are you brown, like venous insufficiency? Although this one, I'm going to show you another slide, bigger slide, but it's the only one I could find was due to tetracycline. Or is it purple-blue and you have an extensive left leg or right leg DVT? We should feel your groins. Do you have lymph nodes that are palpable? We should look at your feet. Do you have tinea pedis? In that right lower corner, you'll see a great example of tinea pedis. In lymphedema, that can be deadly because you can get recurrent bouts of cellulitis. Do you have a Stemmer sign, which we've already heard about? And we should examine your pulses in your groin, behind your knee, and in your feet. And then there are a whole bunch of blood tests that we can do, and more than I'm just mentioning here, but we want to get a complete blood count. We want to look at your liver, your kidney, your thyroid. We want to do a D-dimer to see if you've had a blood clot. We might want to look at a BNP to see if you have heart failure. We'll look at your urine. Are you spilling protein? And we might get a chest x-ray. We might get an ultrasound of your legs. We might get CAT scans or MRs. We might get an echo or a lymphoscintigram. So these are all things that the clinician has available to them, but still a history and physical is much more important, and thinking about the differential diagnosis. So this is an algorithm that I won't go through in any more detail, but about everything I just mentioned: a good history and physical, and then use your lab, but use your clinical skills. And in the bottom right-hand corner is other. So let's talk about other causes for swollen legs. And I couldn't find a better example of venous insufficiency than this, but again, this is due to tetracycline. But this might be a way a patient with chronic venous insufficiency would present to the physician's office. It's often overlooked and underappreciated. As many as 1 million or 6 million people in the U.S. have venous diseases or skin changes. 25 million of us have varicose veins, and many have a venous ulcer. These ulcers are typical. We can make the diagnosis more easily if you have the ulcer than just the skin changes, but this is a great example of chronic venous insufficiency. It's due physiologically due to ambulatory venous hypertension, and patients will have severe pain at times or mild pain. They might complain of cramping, fatigue, heaviness, itching, or throbbing type pain. And generally, the diagnosis can be made clinically. As you see here, we have all these great examples of venous insufficiency. Again, pitting edema. In the left lower corner is corona phlebitic. I love using that in my patients. I think you have corona phlebitica. And they kind of look, and I think right away they think this guy's pretty sharp, knows what he's talking about. And then I just mentioned that it's ankle flaring. That doesn't sound as exciting. So I love corona phlebitic. And the other one is in the upper right-hand corner, lipodermatosclerosis. Now, that's one you have to practice in the mirror several times before you can get it right. Lipodermatosclerosis is bad venous insufficiency, and the skin gets hard and thick and very painful. And then we have one in the middle, atrophy blanche, which is kind of a form of very painful form. So how do we treat that? Well, healthy lifestyle, ideal body weight. If you're overweight, we may consider surgery. Compression garments are very, very important. The key here is that if you have peripheral arterial disease, something called, and a test we use, an ABI, an ankle brachial indice, check the blood pressure in your arm and ankle, and if it's less than 0.5, then you might not benefit from compression therapy because your arteries are bad. But we do good wound skin care, pharmacological therapy. We might try horse chestnut, also known as Venustat, or Trentol, also known as pentoxyphylline. Exercise and endovenous interventions may be helping. Now, lymphedema, LY, can be unilateral or bilateral. It's an abnormal accumulation of interstitial protein-rich fluid. And I bet you many in this audience, and if I asked for a show of hands, would say, my doctor said I had lymphedema. And vascular surgeons are prone sometimes, I hope there aren't too many of you in the audience, but to make that diagnosis error as well. Lymphedema and lipedema are different, as you well know. So there are primary and secondary forms. The more common ones we see are secondary due to chronic venous insufficiency, infections, surgery, radiation therapy, tumor, or trauma. And the onset can be insidious, like lipedema can be. It can be unilateral or bilateral. It can be painless, however. So lymphedema classically is painless, and as you well know, lipedema is not. The edema is initially soft and pitting, later becomes fibrotic. You can get a dorsal hump called a buffalo hump. You can have the positive stemmer sign, which we've already heard about. You can get exaggerated skin creases that you see here in this picture, squaring of toes, and sometimes a podo-orange late sign indicating long-standing lymphedema. And we can make the diagnosis clinically most of the time, but we can use a test called a lymphocinogram. We sometimes do a duplex to make sure you don't have underlying venous disease. And at times they'll do a CAT scan or MRI of your abdomen or other areas to look for another cause of such as obstruction. Treatment, meticulous skin care, because individuals with protein-rich fluid are prone to recurrent infections called cellulitis. Physical therapy, manual lymph drainage, compression garments, intermittent pneumatic compression. And then exercise is very important, educating your patients, and then, of course, surgery as well. Now, phlebolymphodema is a little more well-publicized. Again, you often have corona phlebicatica, more likely in women than men, and this is due to chronic venous insufficiency and lymphedema as well. And what happens, the lymphatic transport initially is continuing to work in these individuals, but later it becomes overwhelmed, leading to secondary lymphedema. If you see in the upper right-hand corner the bowling pin, sometimes people refer to this as the bowling pin or the inverted champagne bottle because the leg really becomes tapered. And that slide I showed you on lipodermatosclerosis looks like that. The skin gets very fibrotic. It's usually unilateral, but can be bilateral. And we do imaging to make the diagnosis with ultrasound. Again, we might use CAT scan or magnetic resonance venography. I have 2 minutes to go, so I think my slides get cut off at that moment, or I do. And we might use intravascular ultrasound to make sure we're not missing a lesion higher up in the groin. Now, the treat both the lymphatic and venous systems, ideal body weight, skin care, endovenous interventions, maybe a stent or so in the groin area, or sclerotherapy are also used, and then, of course, compression garments. Lipolymphedema is lipedema that progresses to lymphedema, and I'm getting near the end. It's rare, but we think it's increasing, and it's a result, some say, from fat deposition causing damage to the lymphatics and capillary system. I'm sure Karen may have other ideas about that, but I'll defer to her. These individuals no longer have the foot spared, so you have lipedema, and now you've developed lymphedema. You probably have a stemmer sign if you have this. Lymphoscintigraphy may be helpful to show the lymphatic damage. Again, we would do a duplex to make sure you don't have underlying venous problems. And then we would use the same things that we do for other swollen legs, decongestive therapy, manual lymph drainage type, and compression garments. Now, phlebolipedema, you have hyperpigmentation, as you can see here, and this is venous disease with lipedema, no stemmer sign, but you have the ankle cutoff sign. And I slide again from Steve Dean at Ohio State, a wonderful physician, the smartest guy I know. Phlebolipolymphedema, this is pseudotumor, massive localized lymphedema, and lipedema and chronic venous insufficiency. So, and that one you could see the, I guess I can go back here, the discoloration around the ankles. And I think I'm going to end on time. I'll show you this is a differential diagnosis of the swollen legs, of which I've just mentioned, but as I told you, there are many, many other causes. So my role here, or my thoughts, is before you talk to a doctor, choose one trained to listen. Thank you.
So I have no disclosures. The outline for my discussion of lipedema is as follows. I'm going to define it. I'm going to present the histology and infer some pathophysiology. I'm going to talk about the prevalence, the inheritance, and I'm going to help you differentiate lipedema from other edema conditions and obesity. And I'm also going to talk about treatment. So lipedema literally means edema or fluid or swelling in the fat. There are other names for it like lipoedema in Europe. It's also known as lip for short. And I want to give a shout out to any of the lippy ladies who are streaming this talk right now. Lipedema is often confused with lipidemia. So if you go to your doctor and say, I think I have lipedema, they say, oh, well, we'll get a lipid profile on you. But lipedema does not mean increased blood fat. It means something completely different from that. It's also not lymphedema. Lymphedema means that there's some sort of dysfunction or damage to the lymphatic system. And although people with lipedema can go on to develop lymphedema, they're not the same thing. So let me go through this definition very carefully. Lipedema is a painful fat disorder. If you squeeze your fat, does it hurt? No. It's not normal for it to hurt. So there's something wrong with these patients who have painful fat. It is a fatty enlargement of the limbs. It's almost exclusively seen in women by the time they reach the age of 30. And its etiology remains unknown, and it's grossly underdiagnosed. So it was first described by doctors Allen and Hines at the Mayo Clinic in 1940. And they, in 1999, provided 119 cases and provided a diagnostic criteria, and I modified it a little bit. So again, it's almost exclusively found in women. It's bilateral, it's symmetric enlargement of the extremities, and there's minimal involvement of the hands and feet. There is minimal pitting edema, so when you put your finger into the fat tissue, it doesn't pit. So Kaposi's stemmer sign is negative, and I'll show you that in a second for the med students who don't know what that is. There's pain and tenderness on pressure, as well as at other times. So people with lipedema will say, you know, my legs really ache, my fat hurts, I've got shooting pain through the fat in my legs or in my arms. There's increased vascular fragility, meaning they get easy bruising, so they bump into something and boom, a big bruise appears. And it's not small, it can be actually quite large. Varicose veins are very common. When they elevate their legs at night because they hurt so badly, the fat doesn't decrease. And importantly, if they lose weight, this lipedema fat does not go away. So I'll say that in a different way. If they diet or they reduce their calories, this lipedema fat does not go away. The swelling in the tissue worsens if they stand for a long period of time, and it also is worse in hot weather. There's a distinct disproportion between the upper part of the body and lower part of the body, and I will show that to you. The arms are affected less commonly than the legs, but I really do think it approaches 80% if you know how to examine the tissue properly. And there's also some hypothermia of the skin. There are also different stages of lipedema, and I want to go through this before I show you pictures so you understand. So the skin in stage 1 appears very flat, but there's a lot of subcutaneous fat. And when you palpate it with your fingers, it feels like little frozen peas, or like a Beanie Baby, if you have had one of those, or styrofoam balls in a plastic bag. So if you feel your fat on your arm, is your fat smooth and soft? Yes, it is. So if you're feeling little hard nodules in the fat, there's something different about that fat. In stage 2, there's a subcutaneous induration. You primarily see this as in the skin, but also you get these walnut or apple-sized indurations as well in the tissue. And the skin looks like a mattress, kind of like cellulite on steroids. And then in stage 3, you get these really large indurations in the tissue, and there's a lot of deformity. And it's really unfortunate that a lot of ladies and some men have actually gotten to stage 3. So here are the different stages so that you can see them. So in stage 1, you can see that the skin is very smooth here. And there's a lot of excess fat. And you can see it at the ankles, and then it just stops. And you can see that the foot is essentially normal. And here's stage 2. We've got this mattress-like look to the thighs, although that doesn't look so clear to me now that I'm looking at it. And then there's these little walnut or apple-sized indurations on the medial knee. And again, the feet, completely normal. And then here's a woman with stage 3. Now, granted, she likely has obesity at the same time, and they can overlap. But you can see these large lobules of tissue here, and you can see that they're actually almost covering her feet. Here's another example that I published. Here's a woman with stage 1. You can see her upper body has well-defined musculature. She works out constantly. And then you can see that her legs are still fatty, and this is after 2 liposuction procedures. In stage 2, you can see these indurations in the skin, again like a mattress, and then these bigger indurations in the fat tissue, and especially down here. This is unusual to have fat. Usually when you touch your leg, you have bone right under your knee, right? Not so in lipedema. And then this is stage 3, gross deformity of the tissue. So this is how I palpate the tissue, and this is kind of funny because I was on the medicine wards in February, and I took my whole team in to see a patient who had lipedema, and they could all feel the nodules and the fat. And I know that they were showing people like, this is how you do it. This is how you palpate lipedema. But this is what I do. And I'm rolling my fingers around in the fat tissue to find those little nodules in the fat. And you can also dance your fingers to cause those little nodules to bump against each other. So to make things a little more complicated, there are different types of lipedema. So in type 1, only the buttocks are involved. In type 2, the buttocks all the way down to the knees are involved. Type 3 is buttocks down to the malleoli. So it's not the ankle. The fat actually wraps around the malleoli, and again, the foot is normal. Type 4, very rare. I've never seen it where only the arms are involved, but I do see the arms involved in stage 1 through 3. And then type 4, I've seen a couple cases of that where they grow a ton of fat just below the knee. It's a very, very odd presentation. And this is an example of type 4. You can see that her forearm is completely normal, but her upper arm is ginormous. So she's lost some elasticity in her skin. So I really want to drive home the point that lipedema fat cannot be lost by reducing your calories or by exercising. So this is a 34-year-old woman. She dieted for a year, basically only ate salads, and she exercised daily for hours. And I think you can see clearly that she's got a nice tiny little waist, but she's got increased lipedema fat on her lower legs, and these pockets of fat are abnormal. And then look at those normal feet. Completely normal. Why? Because she's exercising. Her feet are really working. This is another classic sign of lipedema where you've got this cuff at the ankle. You could call it a trouser deformity or an ankle cuff. And again, the foot is normal, Stemmers is negative. So I did mention that lipedema can progress on to lymphedema, and I want to explain that right now because it's a secondary lymphedema. It's not a primary lymphedema in this condition. And when you have lymphedema along with lipedema, we call it lipolymphedema. And it's also called stage 4, which isn't my favorite way to refer to it, but again, it's a secondary lymphedema. And when you pinch up the skin on the foot, and you can actually just pull up skin, then Kaposi's Stemmer sign is negative, or Stemmer sign is negative. So there's no fluid in the tissue, and you can do that on your hands easily. If you have lymphedema, and you try to pinch up the skin, you can't because it's so full of fluid. So you just get this large chunk of tissue. So in stage 1 through stage 3 lipedema, Kaposi's stemmer sign is negative. It's positive with lipolymphedema. People with Dercum's disease have many fatty nodules on their body. Sometimes a patient will come to me and say, I know I have 3 large lumps on my body and they're painful. Do I have Dercum's disease? And what I find is that the lumps appear in a background of much smaller lumps. So if you palpate the tissue around the lumps that they noticed, you can actually feel smaller nodules in the tissue. And it tends to be very diffuse and pervasive, these small nodules in the tissue. If a person just has a single lump in their tissue or maybe 3 nodules on their body, it's unlikely that it's Dercum's disease. However, with that caveat, some people with Dercum's disease who have thousands of lumps on their body have family members with 1 lump or maybe 3 or 4 lumps. But in those family members, they're not painful at all. So there's something different that's happened to this person who has Dercum's disease, something different in their genetics that has allowed these lumps to progress. Also, I meet a lot of women who have lipedema, who have lumps in their tissue, and they wonder if they have Dercum's disease. And really, we don't have the answer to that. In my opinion, if a woman has disproportionate fat on her body, she's smaller on the top, larger on the bottom, her tissues are heavy, she has many diffuse small nodules in her tissue, and 1 or 2 large lumps, she still has lipedema. She does not have Dercum's disease. Dercum's lumps appear on the body all over. They can appear on the arms, the back, the chest, the abdomen, and the legs. They also can appear on the head, the hands, and the feet, but much less often. Typically, the lumps appear on the chest, usually on the side of the ribs, but many people also develop lumps on their forearms or possibly on a thigh or a lower leg. But I would say the most common part of the body where a lump will develop in Dercum's disease is on the chest. The things that tend to slow down the lumps, in my opinion, that I've learned after working with my patients over time are 1, diet. So people who are eating a very clean diet, and by a clean diet I mean lots of healthy fruits and vegetables and lean protein. You don't necessarily need to go towards a vegan diet, but reducing the amount of meat that's eaten, maybe to 2 or 3 times a week, or eliminating it altogether. Some people are able to do that. The second thing is making sure they get lots of exercise to help the lymphatics continue to function. And the third is some supplements that they can take, which are actually come from food, to help improve inflammation, decrease reactive oxygen species, improve lymphatic pumping, and also decrease the amount of leakiness that we find in the capillaries and the lymphatics. So there are some doctors that are able to diagnose patients with Dercum's disease. These doctors tend to be dermatologists, some are rheumatologists, some are surgeons that have removed the fatty lumps from patients with Dercum's disease and have researched it further. There are some reports of liposuction for Dercum's disease in the literature, and if we look at a pain scale of 0 to 10, 10 being the worst pain you ever had and 0 being no pain, liposuction can actually reduce overall pain by a point, which may not seem like much, but when you're living with pain every day, reduction in a full point is actually a lot. The only problem with liposuction for Dercum's disease is that it tends to recur. So people have to be prepared that the liposuction and the liposuction effects for reducing pain are not going to be sustained over a long period of time. I think we really need to better understand liposuction for Dercum's disease. It does seem to require some different methodologies, and it may be actually better to remove a larger amount of tissue
rather than to undergo liposuction, but we just need more research in this area. And I think really you have to personalize that treatment to the patient. There is some research going on in Dercum's disease. I collaborated with a Swedish group at the Karolinska Institute, and our goal is to phenotype people with Dercum's disease very accurately and also do some immune investigations. So we're going to be looking at all of the inflammatory cells in people with Dercum's disease to see if any of the inflammatory cells are involved in the disease process. And that is going to drive treatment modalities. And that actually is going to be starting in the fall of 2015. We are actually actively raising money for research. I do have some research money right now for Dercum's disease. And our goals are to repeat a questionnaire that I've done in the past to see how people progress in terms of Dercum's disease, to phenotype people with Dercum's disease, and also try and learn about different treatment modalities, for example, stem cell infusions in people with Dercum's disease. People with Dercum's disease tend to have pain as their main complaint. And treatment of pain is very personal. What works for one person may not work for another. So treatment modalities for Dercum's disease tend to start with non-steroidal anti-inflammatories, which means like ibuprofen or naproxen or Tylenol or aspirin. When these fail, they tend to move on to antidepressants, for example, Cymbalta. They also can involve nerve-specific pain medications such as Neurontin or pregabalin, and those actually have been very successful in improving pain. People also tend to use opioids, and that can be pretty risky because people with Dercum's disease have a really high level of pain, and the amount of opioids that they can take can rise dramatically, and that's a big concern because opioids suppress their breathing center in their brain, and I've lost a couple of patients who have Dercum's disease because of the use of opioids. Another treatment modality includes the infusion of lidocaine by IV or ketamine by IV. Lidocaine is typically used as a numbing agent when you have your tooth treated by the dentist or for surgical procedures. And for some reason, because lidocaine affects sodium channels in nerves, it relieves pain in Dercum's disease, and it can actually last for months. Some people respond to lidocaine and some people don't. The unfortunate part about this procedure is that it has to be done by somebody knowledgeable. You have to watch the heart during the procedure because it can stimulate an arrhythmia, so not many centers actually offer that. Also, there's ketamine infusion IV that has been shown to work for a number of my patients with Dercum's disease, but again, unfortunately, not many centers do that. Things that help prevent or decrease pain in Dercum's disease include manual lymph drainage and compression garments. And we think that there's a lymph component to the pain. And swimming also helps improve pain. Whole body vibration helps to improve pain. Any kind of manual therapy on the skin, such as microcurrent or Hivamat or cold laser or low-level laser, these are all temporary pain modalities that are anti-pain modalities that people can use that have Dercum's disease. I just wanted to say a few things about the difference between lipedema and Dercum's disease. I think it's really hard at a big conference like this to distinguish the two, exactly what should be done for Dercum's disease and exactly what should be done for lipedema. So I did hear that some people with Dercum's disease here at the conference are feeling kind of bad because there's a lot that seems to be geared towards a really healthy lipedema lady that doesn't have a lot of pain. So in terms of exercise, I thought that Sonia made it clear, and I don't know if everybody heard, but if you have Dercum's disease, to schedule an intense exercise program is probably not a great idea right away, because you probably don't feel very good at all. You only have so many spoons in a day, and you need to use those spoons to get up, get dressed, to eat, to take care of your kids, or whatever you need to do. So I would I would say everything you hear, if you have Dercum's disease, especially the type where you don't have very many spoons for a day, you want to take everything slow. It's a lot of information that you've received today, and you definitely don't want to start taking 10 supplements tomorrow. You would take one or a half a pill or a quarter of a pill, or you could lick the bottle. Swimming is great for Dercum's disease, but you're not going to swim a long period of time, right? Walking is good for Dercum's disease, but you're not going to walk far. If you get up and walk around the room once, yay. Tomorrow it might be just once again, and the next day it might be a room and a half. But everything very, very slowly. But the fact that you are even trying to do something to get better is what this is all about. And these are all tools that you take home and you're going to sit with, and you're going to do your breathing. You probably aren't going to do the intensive tapping that Italy was doing, because even I abuse Dercum's patients in my clinic. I go like this, and they jump like this because it is so darn tender. So if you're not going to do that intense tapping, right, you're going to just do the gentle parts or you're just going to breathe, right? So I hope that helps the Dercum's crew.
Okay, my background is different. I'm a physical medicine and rehabilitation, and I trained in lymphedema about 17 years ago. So I came to lipedema as a consequence of seeing patients with lymphedema. So let's see, I have no disclosures. Lipedema is a symmetric edema in the lower limbs. As all you know, I'm mostly located at the hips and thighs. It's a chronic disease, mostly in females, though I will say that I examined some of my patients, being males, and found some nodular fat. I will guess those patients, if they have the estrogen trigger, they will have lipedema. The hypothesis is really estrogen-regulated polygenetic disease leading to vascular and lymphatic abnormalities, causing inflammation affecting peripheral nerve. I think it's the best hypothesis I found in the literature I reviewed. Main disorders considered for differential diagnosis will be lymphedema, either primary, that you're born with it, or secondary, that will be because your lymphatic system is impaired, you were removed of lymphatic nodes, or you had radiation due to cancer. Obesity, lipohypertrophy, and venous edema. The staging, I found a little bit challenging trying to stage, and when I review the literature and when I review my patients, I found different kind of way to describe the stages. So for the stage 1, most of the description was a thick leg, and they have my patient has subtle skin indentations, mostly on upright position. They do have very soft skin, but they have a small fatty nodules. And those nodules, I will say, is following mostly the main lymphatic pathways. Stage 2 is a more pronounced skin indentations. Fatty nodules are palpable of but different sizes. There's a loss of skin elasticity, and superficial hematomas is mostly present. For stage 3, there's more pronounced skin stretching, prominent hanging fat pads and masses, mostly in the inner thighs and knees. But I have to tell you the truth, I have seen patients different fatty deposition, so it's not everybody follows the same description. Upper arms are usually involved, although I will say that for stage 2, I will have patients with early upper arm involvement. You start to see some hardening of the tissues and vascular fragility. Stage 4, then you have the large fat masses hanging, lobules on legs and arms. Varicosities usually are present, and variations of skin changes, including trophic changes, are seen. And hardening of the skin and tissues, we'll see subcutaneous tissue, joint deformities that I have seen mostly at knees and ankles and toes. Most patients will say, doctor, I have pain on my legs, I have easy bruising. My legs or arms are swollen. I have some fatty lumps on legs, abdomen, and arms. I feel heavy. Heaviness is something that is variable. I would say that basically stage 3 and 4 will say I have more heaviness on my legs. I feel weak on my legs. I feel fatigue. I'm tired. I have this swelling fatty deposition that has been worse after by puberty, or maybe after pregnancy, contraceptive pills, or indeed patients that are having estrogen or hormone replacement. The pain score, I think pain has been very underestimated in patients with lipedema or lipolymphedema. We found like 3 patients of the 12 patients that I'm going to present has no pain. 2 have mild pain, 3 had moderate pain, but 6 has severe pain in a scale from 0 to 10. And being a physiatrist, I do manage pain, and I have not seen any patients with lipolymphedema being managed. The pain is not managed, basically. In the physical examination, most of my patients has a symmetric fatty deposition of the legs, abdomen, and arms. Superficial varicosities may be present, bruises, tenderness to palpation. It's a very different situation patient by patient. I would say that the peritibial area is more painful, although when I examine other fatty areas, they do have pain in other fatty deposition areas. They have hypermobile joints, most of my patients. Non-pitting edema, usually feet are spare. Later, at stage 3 and 4, we do see the stemmer sign, but even in lymphedema patients, a stemmer sign is only present in 50% of the patients. So we are not expecting of all the patients having lipolymphedema stage 3 and 4 to have a stemmer sign. So stemmer sign is the thickened skin at the base of the second toe or second finger, and obviously it's positive in most of those patients. The BMI in my patients was about 40.44. So if you see the graph, you see patients even with stage 1, they have 37 up to 57.1. So you have definitions of the BMI in the slides. That's more than 25 is obesity, more or equal to 35 with 2 comorbidities such as hypertension or diabetes will be morbid obesity, and more than 40 will be morbid obesity. So as you see the staging from 1, you can have a 47 BMI, but certainly stage 3 and 4, they're all above 40. Comorbidities. I found my patients not have more than 10% of diabetes or glucose intolerance. They do have high blood pressure. This is not all of the patients, but this is what I have found. Obesity, arthritis is mostly at spine, lower spine, hips, and knees. Thyroid disease could be hypothyroidism, that's the most common, goiter or autoimmune thyroiditis. Fibromyalgia, there is a challenge for diagnosing having lipedema. Because of the points of tenderness, you do have the lower back, the lateral aspect of the hips, and you have the inner aspect of the knee. So you have 6 points of fibromyalgia that you will need only 11 to do the diagnosis out of 18. So it is really challenging because the patient has pain on their fatty tissue, so certainly in the same area where you're gonna check or touch or palpate for the fibromyalgia points. I found autoimmune disorders like systemic lupus, SLE, RA, polycystic ovaries, IBS, gluten and lactose intolerance, breast cervix malignant neoplasm, carcinoid tumor, adrenal adenoma, bronchial asthma. So in my patients, the number 1 condition of comorbidity was hypothyroidism, followed by osteoarthritis, hypertension, hyperhomocysteine, vitamin D deficiency, hyperlipidemia, venous insufficiency, elevated liver enzymes, and IgA deficiency, followed by elevated factor VIII clotting, cancer or tumors, adrenal insufficiency, fibromyalgia, diabetes, glucose intolerance, neuropathy, and vitamin B12 deficiency. Most of my patients, this is very interesting. At least 2 or 3 of my patients that we included in this data, they have had gastric sleeve and gastric bypass. The issue here, they are enduring issues of vitamin deficiencies after iron deficiency, after they have done this gastric bypass or gastric sleeve, but they still have the fatty deposition, and it's still nodular, and it follows the same pattern as the lipedema. It doesn't go away. Some of the patients have had removal of excess skin after bariatric surgery, and I will say again, they still have the same pattern, even that they have done the excess skin removed. We have other patients that have hysterectomy, cholecystectomy, total knee replacement because of the arthritis at the knee, lumbar laminectomy, and fusion. The abnormalities, low vitamin D, usually less than 15 nanogram per milliliter, elevated CH50 as the presence of chronic inflammation, elevated high homocysteine that when present, you can have strokes and predisposed to strokes and cardiovascular disease, heart attacks, elevated cholesterol, low HDL, high LDL, elevated fasting blood sugar, high A1C, immunodeficiency as low IgG, IgA, elevated IgE, elevated liver enzymes with fatty liver, elevated clotting factors, predisposing a higher risk of developing deep venous thrombosis, elevated creatinine clearance, low eGFR, so those patients have kidney insufficiency, low hemoglobin level, iron deficiency, anemia, and cortisol. I have adrenal insufficiency as well as elevated cortisol in the morning. Lymphoscintigraphy is a main study that I will use in all my patients. It consists of an intradermal and or subcutaneous radiotracer injection between toes and fingers. What happened is, the main reason we do this is to evaluate the lymph flow, if there's any obstruction, abnormalities of the lymphatic system. So what's going to happen, everybody's a little bit afraid of having this test. It's a little bit of a prick between your fingers or your toes, and what we're going to inject is a sulfur colloid that will be transported into the regional lymph nodes and the lymphatic system. So it's routinely used for evaluation of a swollen leg, and this technique is important to know the pathophysiology of the edema. So this will be a normal lymphoscintigraphy. We will see in the 5 minutes that will be the immediate film that you don't see mostly of the growing lymph nodes, but I will say that by 20 minutes to 30 minutes, we are expecting to see the lymphatic lymph nodes and some of the pelvic channels, and 150 minutes is obviously some sufficient time to see the inguinal lymph nodes and the pelvic lymph nodes. In my patients, 100%, and still today, they present lymphatic abnormalities, starting at stage 1. I was very much surprised that stage 1 has lymphatic abnormalities. They were either enlarged, delayed lymphatic flow, lymph pooling. They may show collaterals or non-visualization of the lymph nodes or enlarged lymph nodes. So I will say definitely this will be lipolymphedema since stage 1 up to stage 4. So venous insufficiency is so common in 92% of the patients. I rarely see, though, patients with the venous thrombosis. All the patients will have an abdomen pelvic CT scan, and the most common finding will be the fatty liver, enlarged liver, gallstones. We can see enlarged pelvic lymph nodes, atherosclerosis, hiatal hernia. We have found some patients with pulmonary nodules, constipation, adrenal adenoma, and pancreatic fatty atrophy. Echocardiogram. We do echocardiogram in all of our patients. We have found 67% that they have left ventricular hypertrophy, mild diastolic dysfunction. So it means that those patients that even there have not been diagnosed with arterial hypertension, the heart is having some issues very early. So it is important that patients should be assessed in this respect. Treatment, minor lymphatic drainage, decongestant therapy, application of multi-layer bandages as foam and short stretch bandaging is a main goal of treatment. Use of compression garments will be arm sleeves. Very seldom I will have patients accepting use arm sleeves for lipedema and the upper extremity, either capri or longer than capri pantyhose with micromassaging garments are very tolerated. Low pressure is better tolerated than high pressure, I think because of the pain issue. Night garments and inelastic compression garments are very poorly tolerated. It's important the patient get good sleep, at least 7 to 8 hours, and exercise. Exercise would be low impact aerobic exercises, underwater exercises easier, general stretching, strengthening with progressive resistance and elastic bands. So you don't have to be worried that if you do exercise, the edema is gonna get worse. That doesn't really happen. Chronic lymphedema will be causing immune dysfunction, as well as recurrent infection, chronic inflammation, and progressive fibrosis, and more adipose tissue deposition. Diet should be anti-inflammation diet with high omega-3, green leafy, dark berries, avoid allergic, sensitive foods, and reduce simple sugars, eggs, and dairy gluten. Interventions, we have to correct the deficiencies, either any kind of vitamins or minerals, and we should use the antioxidants, anti-inflammation. Selenium's already mentioned in a dose of 200 micrograms once a day. Bioflavonoids, it could be contained in vascularia, with the most important citrus flavonoid will be diosmin in the dose of 500 once to twice a day. And acetylcysteine, I have found very beneficial for my patients. Beta-glucans, very important that they will be sure that they are not allergic to mushrooms or barley, wheat, and rye, in the order of 500 milligrams per day on an empty stomach with 8 ounces of water. Liposuction, very brief. I had a patient with stage 1/stage 2. She was very driven to have surgery. She has a water-assisted liposuction. Her lymphoscintigraphy showed lymphatic abnormalities, as you see, very early in time. She had the liposuction with good results, and she continued to do her diet exercise to control her lipolymphedema. Conclusion, I think the lymphatic abnormalities are very evident in early stages, and we have a wider rate of comorbidities and multiple treatment and interventions. Effectiveness and long-term, I think, is going to be something in a question mark right now. We will see as we proceed how we're going to do better in the future. Thank you very much.
I want to introduce to you Karen Beltran. She is an undergraduate student at the University of Arizona. And through some funding, she was given money to do research with me. And she is going to talk today about comparing lipedema and Dercum's disease, because sometimes it's difficult. And I'm sure there's at least one of you out there who you've come to my clinic and I'm like, well, you look like lipedema, but everything else is Dercum's disease. And I think it's really important to have Karen presenting today, because one of the most important things to do as we age, I feel like I'm getting really old, is we need to train the next generation. And Karen wants to go on to medical school. So she's already going to go into medical school knowing about lipedema and Dercum's disease. And I bet you she trains the other students that are with her. So without further ado, Karen Beltran.
So today I wanted to talk about the comparison between lipedema and Dercum's disease. And so this is the research that we have been working on with Dr. Herbst. And so these are my disclosures. And so in this diagram here that we got off the FDRS website, you can see that all these fat tissue disorders are very similar and have a lot of similar symptoms, but also some differences. but today we're going to focus on Dercum's disease and lipedema. And so as you can see off these pictures that we got off the literature, lipedema and Dercum's disease are very similar externally. So that makes it very hard to distinguish and diagnose. And so in this table here, off of different publications, we can see the similarities and differences between lipedema and Dercum's disease. And so as you see, pain is more common in Dercum's disease, whereas the affected areas usually in lipedema are the lower extremities of the body, where in Dercum's disease, usually the trunk is more affected. And also some other factors that we focused on in our research was diabetes, which is more common in Dercum's disease, whereas also we looked at hypermobility, which is what we're going to talk about later. So we know that gynoid fat is healthy fat, and gynoid fat is located in the lower extremities of the body and is known to be protective against diabetes and other metabolic disorders. Whereas android fat, which is located in the above the waist, is known to be associated with inflammation and other metabolic diseases. And so women with lipedema who have a greater distribution of gynoid fat can be protected against metabolic disorders like diabetes. And so that is our hypothesis. And also those women who have more inflammation are at greater risk of having symptoms and signs associated that are similar to Dercum's disease. And so our aim for this study was just to look at the similarities and differences between lipedema and Dercum's disease. And so these are all the parameters that we looked at, which included affected adipose tissue that had nodules, edema, or fibrosis. And also we looked at CH50, which is a marker for inflammation. And so from previous data, we saw that hypermobility was common in lipedema, and also diabetes was very common in Dercum's disease. So we wanted to confirm these numbers in this study. And so how did we do it? We looked at data and collected data on 300 patients in Dr. Herbst's clinic who were diagnosed with lipedema and Dercum's disease. And so these were all the parameters that we looked at, which included the Batten criteria and the Batten score, which would assess hypermobility. One important thing to note is that the men in the Dercum's disease group was kept in the study because we saw how removing them didn't really change the outcome of the data. And also, there was a group of people who were diagnosed with both lipedema and Dercum's disease. And so this just comes to show how it is very difficult to distinguish and diagnose these two disorders. But for the purposes of this presentation, we won't be talking about that group. And so what did we find? What we found was that there was a significant difference in the ratio of females to males. And especially in the lipedema group, there was a ratio of 159 females to 1 male, whereas in the Dercum's disease group, there was a ratio of 79 females to 15 males. And we see also a significant difference in the average weight and BMI. It was significantly higher in lipedema compared to Dercum's disease. And in the bottom table, what we see is the distribution of the different stages of lipedema and the types of Dercum's disease. And we see stage 2 was the most common in lipedema, whereas in Dercum's disease, mixed and diffuse were more common, which they usually have small nodules that are very similar to that tissue in lipedema. And so what we saw also was hypermobility was significantly higher in lipedema. And what we used was the Batten score, which assesses hypermobility. We also saw, this shows the nodular fat distribution in different body areas. And what we see here in the bottom table is that lipedema is significantly more affected in the lower part of the body. And also, if you see in the upper table, you see the upper arms are significantly more affected in lipedema. We also looked at heavy tissue areas, and we see how lipedema was significantly more affected with heavy tissue areas. And so these were usually located in the legs, the groin, the hips. We also looked at positive stemmer sign, and so stemmer sign shows the fluid in the tissues. And so what we found is that women with stage 2 and 3 of lipedema have significantly more of a positive stemmer sign compared to stage 1. And so we also looked at feet stemmer sign. And what we saw is that women with lipedema also had a greater, significantly greater percentage with positive stemmer sign in the feet. And so what we know is that fibrosis follows inflammation, and so fibrotic tissue is known to restrict movement of lymph fluid. And so what we saw here is that women with lipedema tend to have more fibrotic tissue areas than Dercum's disease. And so one of our main focuses, if you remember in the beginning, was diabetes. And so our hypothesis was that gynoid fat can be protected against metabolic disorders, and so women with lipedema would have a lower risk for diabetes. And so that's exactly what we found in our study. We see here that Dercum's disease patients had a greater risk for diabetes. Around 16% of them had diabetes, whereas in lipedema, 6% of them had diabetes. And one important thing to note here is that we looked at the obesity rates between these two groups, those who had lipedema and diabetes, and those who had Dercum's disease and diabetes, and there was not a significant difference in their obesity rates. So obesity was not a factor in these results. And I also listed here the different types and stages of lipedema within these groups who had diabetes. And we also looked at the review of systems, and as you can see from this table right here, they have many similarities, lipedema and Dercum's disease, but some differences between them was abdominal pain and shortness of breath were more common in Dercum's disease, whereas visible veins on the legs and easy bruising were more common in lipedema. And so one thing was that fatigue and swelling were very common in both of these groups. We also looked at medical conditions, and what we saw here is that pain-associated conditions like fibromyalgia and migraines were more common in Dercum's disease, and also lymphomas and diabetes, as you saw. We also looked at CH50, and we wanted to look at CH50, which is a marker for inflammation. And what we saw here is that both of these groups had significantly positive elevated CH50 levels. And I'm going to explain a little bit more of what CH50 is. And so CH50, we wanted to see how lipedema and Dercum's disease and the complement pathway plays a role in this, these two disorders. And so what we see here in this picture is how these fat tissue cells in the lipedema tissue, you see how all these macrophages, which cause swelling and inflammation, are around the tissue, whereas in a normal fat tissue, you see there's not all these macrophages around it. And so in this diagram here, I wanted to show you how these complement pathway proteins tend to activate these macrophages, which cause swelling and inflammation. And so that's why we wanted to look at CH50. And so one thing to note is that the population and the sample for this particular CH50 factor was very small, and so more work has to be done in order to see the results fully. And so we also know that lipedema and Dercum's disease are a pain disorder, or pain fat tissue disorders. And so we wanted to look at the average daily pain between them. And what we saw is that Dercum's disease had an higher average daily pain, which was around 6, compared to lipedema, which the average pain on an analog scale from 0 to 10 was 4. And so how can we summarize these results? Well, we found that women with lipedema had more affected part on the lower part of the body, which coincided with a higher BMI and a higher weight. But despite the higher BMI and the weight, women with lipedema had a lower risk for diabetes compared to Dercum's disease. And also we saw how pain syndromes, including fibromyalgia and migraines, were more prevalent in Dercum's disease. And we also saw how abdominal pain, shortness of breath, lymphomas were more common in Dercum's disease. We saw how complaints of fatigue and swelling were common in both lipedema and Dercum's disease. And also, we saw hypermobility was very common in lipedema, and also easy bruising and fibrosis. And we also saw how more patients with stage 2 and 3 of lipedema had a positive stemmer sign versus those with stage 1. And we also saw how CH50 was significantly elevated in both of these groups. And so if you remember the table that I showed at the beginning, we knew the similarities and differences between Dercum's disease and other publications. And so a lot of that was seen in this study. But also we added some factors to it. We saw how hypermobility was present in more than 50% of patients with lipedema, whereas in Dercum's disease, less than 25% of them had hypermobility. Also, we saw how diabetes was significantly less in lipedema, whereas it was more common in Dercum's disease. And so based on these results, we can make some conclusions. And so lipedema fat tissue is more prevalent in the lower part, and we know that it is in a gynoid distribution. So gynoid fat can be protective against metabolic complications like diabetes. And so women with lipedema can develop Dercum's disease. Although the different distribution on the fat like we saw, it seems like Dercum's disease can develop independent of lipedema. Also, hypermobility, we think, can increase the risk for lipedema or vice versa. And so it should be considered a comorbidity of lipedema. And so for the data for the CH50, as I mentioned, it was a very small sample, but the results clearly show that more work has to be done in order to understand it fully. And so based on these results, we can also make some treatment recommendations. And so women with lipedema should be assessed for hypermobility and also treated for it. And so fibrosis is also common in lipedema. So different treatments like myofascial release should also be considered. So a person with Dercum's disease should be assessed for inflammation and insulin sensitivity, and also should be treated to reduce the risk for diabetes. And so heavy tissue areas like the legs, hips, and buttocks were especially prevalent in lipedema. And so hands-on therapy, like in order to reduce this edema, should be considered, which can include compression garments, sequential pneumatic compression pumps, and exercise, including water therapy. And so that's it. Thank you very much. Thank you for your time.